Hi,
Hello.
my name is Eileen Hsich, and I'm here actually representing the HFSA Communication Committee. And we have chosen your presentation as one of the most important to actually be highlighted at this session. And Dr. Eduardo Rame, could you actually tell us about yourself and the place that you're working and your role there?
I've been in the field of advanced heart failure for about 20 years and proudly trying to still contribute to the, I would call it the broader community of mechanical circulatory support aficionados and people engaged. These include bioengineers, these include clinicians, and they also include obviously our training fellows and physicians. I've been at Penn for 10 years. I was the founding medical director of the MCS program, and have been engaged wonderfully with many surgeons and colleagues. That program has been transitioned to my ex-fellow in a wonderful way. And now I am working solely with our teams to try to build more of an acute MCS programmatic presence with the shock programs that are being developed across the country, trying to see for the health system if that was, if that's possible. In terms of what we presented at the HFSA, my topic was Beyond INTERMACS 3, candidate selection and risk and benefit considerations.
Which is such an important topic.
It's been a topic in our field, I have to say, most poignantly for me interacting with this field, with Revive It, that was the clinical trial that was designed by Frank Pagani, Keith Aronson, Doug Mann was on the steering committee, and it almost came to fruition, and that was going to be randomizing patients who were INTERMACS 7 category, functional class 3, at a time point when we had an incredible confidence that survival was being achieved really well beyond what medical therapy could do. And this is 2010, 2012 era. What's amazing is how this field, in a so dynamic fashion, gave us some pause to realize that clinical trial, because I think as clinicians, and this is the beauty of I think what we do, we had to dig deep in our soul. If this was our family member or us, would we have the equipoise to randomize a patient who was actually doing not great? We knew the mortality would be probably a mortality of probably median survival for these patients could have been 3 to 4 years. So the functional class 3 patients were definitely being chosen as ambulatory functioning heart failure patients, not enriched for doing poorly, but with symptoms. And we didn't realize that trial because of pump technology at that time in a dynamic way challenged us. And the challenge was obviously adverse events, the things that make life important, as opposed to just life years lived. It's life years lived out of the hospital and life years lived without risk of stroke and fearing your pump's going to go off and stop and so forth. So the way I address the topic, just briefly, is I showed data from a recent study that was published in April by the group that has put together the MEDIMACS study, which was always originated as a medical arm of INTERMACS, but it's become so much more. It's what I called in my slides the Advanced Heart Failure Registry, not mechanically assisted, and kind of taking a little lesson from Ohio State. I really believe MEDIMACS has been talented like that. It was built by Lynn Stevenson and many centers that collaborated with minimal budget, but it's stood the test of time. It's very internally consistent, and what they published was really important for our field. They saw that in the current era of the data which MEDIMACS was acquired, the INTERMACS 4 and 5 patients for sure have a mortality deficit if they don't receive left ventricular assist device support. The commentary in the Journal of Heart Lung Transplant to that paper was done by a terrific colleague from Oslo, and what he said was very poignant. Although the colleagues have demonstrated that it is time to really think about implanting INTERMACS 4 or 5 patients, he's not convinced that the patients that have a good survival with optimal medical therapy long term are being well understood. Because wouldn't you want to wait if you're doing so well not to have a VAD? And I think that is true. So as always, I think in what we do, we have to get smarter and do more research. I left the talk just giving the teams at the meeting a sense that for us, I think we have to have a refined phenotype, have true categories of how sick someone is, how sick in terms of the burden of heart failure. INTERMACS doesn't capture that as much, the categories. What they capture is who's critically ill, who's less critically ill, who's more ambulatory, and so forth. I'm talking about capturing the patient who's had weight loss over years, and even though they may be ambulatory, INTERMACS 5 and looking good, those patients are probably going to potentially die soon if they've had cachexia recently from that heart failure burden. And I don't think those phenotypes are well captured in some risk score. So hopefully with the biological discoveries we're having in the area of personalized medicine and omics, intersecting that with some really clever, I believe young people are at that nexus now, our young colleagues that are really interested in how data analytics comes into play with decision making. I think we're going to get much smarter. But my concluding element was definitely be eager to think of a VAD for someone who truly has a cumulative burden of heart failure that is significant for you as a clinician to say, this guy's not going to be alive at 2 years. Be confident in your decision to pursue LVAD therapy, and I think we'll keep this field going.
What a great message. Thank you so much, Dr. Rame.
Thank you.